Hello friends, today's discussion is on the case of toxic epidermal necrolysis. So this patient was 67-year-old male patient with a known case of type 2 diabetes mellitus and hypertension on medication. He presented to the outside hospital with a chief complaint of imbalance while walking and the weakness of the both lower part. So they have done evaluation for this patient. For that they did CT which showed age-related atrophic changes, no evidence of hemorrhagic and acute infarct. So the patient was discharged from that hospital with the following medication: tablet Levipil 500 mg PD, tablet allopurinol OD, tablet Ecosprin 75 mg OD, tablet Telma, tablet Neurobion. After this, within 2 days only, the patient started developing rashes, glossitis, and the patient was unable to swallow. There was a lot of secretions from the mouth. So he came to our hospital for further care. On arrival in ICU, the patient's pulse was 96, blood pressure was 130 by 70, respiratory rate was 22, so saturation was 100%, CVS S1 S2 present, RS air entry equal on both sides. Per abdomen was soft and the patient was conscious. And on general examination, we found typical target lesions noted on the trunk and the extremities. Multiple hard vesicles, bullae noted over face, trunk, extremities, including scrotum. Many bullae were ruptured. Palms, erythema was there. Then face diffuse erythema and erosions over cheek. Oral cavity, multiple erosions covered with the slough over hard palate and buccal mucosa was present. Eyes, conjunctival congestion was there. The eyes were red. Genitals, erosions present over prepuce of the penis and the scrotum. Perianal erythema was present. So for treatment, we have started with him on the antibiotic, which was Monosafe. Then pan injection we have given and Dexa 6 mg BD. So this was a lesion of this patient, which showed the mucosal involvement of the lips. Then these are the target lesion which were present on the over back. Then this is the oral cavity of the patient, which showed involvement of the mucosa. And this is the again the picture of the back which showed target lesion and palmar erythema. This is the picture of the bulla. So on 23rd of the January, patient became restless, lesions were worsening, oral bleed were present, skin peel-off were present around the eyes, cheek, back, neck, and forehead. So this was the sloughing of the skin which was present. So we have started this patient. We have started this patient on IVIG. So so initially, before starting IVIG, we have given him on the we have started this patient on the dexamethasone, that was a 6 mg BD and cyclosporine. But despite that, the lesions were worsening. So we have decided to start him on IVIG. So on 24, the skin peel-off were present around the eyes, forehead, back, and neck, and the patient was hemodynamically stable. So the patient's PCT was came out to be high. So we have upgraded his antibiotic to the Piptas. Injection IVIG 10 mg TDS was given. Injection Dexa 6 mg BD was going on, and syrup solid, that is cyclosporin solution 1.5 ml BD. Candid mouth paint was apart from this candid mouth paint we applied, and a gentle eye drop for eye care. So these are the investigation of this patient. So creat was elevated, and also the blood urea nitrogen of this patient was elevated. So on investigation, we figured out this race creat was due to dehydration, which was attributed to the prerenal etiology. On 25th of January, this patient developed tachycardia. So we have taken ECG, which showed atrial fibrillation with fast ventricular rate. So we treated this with the injection cordonon 150 mg followed by 150 mg, and we have given continuous infusion of same, but the heart rate was still not under control. So we have started him on the beta lock 2.5 mg IV stat again. Followed by same dose of 2.5 mg IV. After that, the heart rate was controlled. So for treatment, we stick to the same treatment, that is injection Piptas 2.25 mg IVBD IVTDS, injection Dexa, IVIG, Clexane, and syrup cyclosporin. So these are the investigation of this patient on 25th of January and 26th of January. As we can see, the creat levels were decreasing, and the sodium levels were increasing. Like on 25th, the sodium of the patient was 147. On 26th, it was 152. So on 27th of January, patient has already completed 5-day course of IVIG, and the on examination we have found few blisters have refilled, especially over thighs. Slough noted in the anterior and posterior trunk. The patient developed hypernatremia. The sodium was persistently on the higher side. So we have inserted drive tube for feeding. The patient was extremely restless. And in view of hypernatremia, we have started him on free water. So this was the investigation of the patient on 27th. As we can see, despite starting free water, his sodium was high. His sodium was high. So the possible explanation of this high sodium was again dehydration, because this patient had lost his skin, so he could not. So there was a lot of water loss from his body, water loss from his body. So because of this free water loss, there was a high sodium. So patient's sodium level were persistently high. So again, the treatment of this patient was same. We have continued with the same antibiotic, that is injection Piptas, injection Dexa, Avil, Metexcel, 25 mg BD. We have started for high blood pressure and also for the tachycardia. Syrup Sorid, that is cyclosporin, was continued, and gentle eye drop for eye care. Then on 29th of January, this patient suddenly became hypoxic, went into cardiac arrest. Patient was intubated. We put him on mechanical ventilation. We have taken chest X-ray, which was suggestive of aspiration. But despite all resuscitative efforts, we could not save this patient. So we'll have the brief discussion. So the basic diagnosis of this patient was toxic epidermal necrolysis. So we'll see in detail what is this Steven-Johnson syndrome and toxic epidermal necrolysis, which we can face in ICUs as emergency. So basically, this Steven-Johnson syndrome and toxic epidermal necrolysis are both rare and life-threatening conditions caused by hypersensitivity reaction involving skin and mucous membrane. So Steven-Johnson syndrome is the milder form of pain with the involvement of less than 10% of body surface area, and the condition is called as 10. Now that is toxic epidermal necrolysis if affected body surface area is more than 30%. The involvement of 10 to 30% of body surface area is considered to be overlap of Steven-Johnson syndrome and toxic epidermal necrolysis. The mortality rate of toxic epidermal necrolysis can be up to 3 times higher than that of the Steven-Johnson syndrome because of the extensive skin involvement and secondary complications. So drug reactions are the most common cause of Steven-Johnson syndrome and toxic epidermal necrolysis. Drugs like antibacterial, allopurinol, sulfonamide, anticonvulsant, and steroids are found to be associated with increased risk of SJS and 10. Among these drugs, sulfonamide, penicillin, and anticonvulsants are commonest implicating agent for SJS and 10. So among non-drug infections causes, the Mycoplasma pneumonia in adult, herpes simplex virus infection in children are known to cause Steven-Johnson syndrome and toxic epidermal necrolysis. A rare occurrence of toxic epidermal necrolysis in patients with severe aplastic anemia after allogenic hematopoietic stem cell transplantation has also been reported. Lastly, the vaccination is also implicated as an inciting factor like human papillomavirus, mumps, measles, rubella, hepatitis B, influenza, anthrax, and tetanus vaccines. The primary cause for the development of TEN is a massive T lymphocyte mediated immune reaction causing destruction of the keratinocyte expressing foreign antigen. An increased amount of inflammatory cytokines like tumor necrosis factor alpha and interleukin 6 are found in distal fluid. They recruit the cytotoxic T cell to the epidermis, causing cell death by inducing apoptosis. A cascade of intracellular enzyme called caspase is activated when cytotoxic T lymphocyte come in contact with the target cells. The patient may present with the prodromal phase of fever, malaise, cough, stinging eyes, and sore throat. Other symptoms include erythematous rashes, bullae, separation of large sheets of epidermis from dermis. Cutaneous lesions include diffuse erythema with target-like lesion, blisters, and erosions. Target lesions are less than 3 cm in diameter, round, and have three concentric zones. Central area of the dusky erythema, middle paler zone of edema, and outer ring of erythema with defined edge. Target lesion plus involvement of at least two mucous membrane can comprise the diagnosis of Stevens-Johnson syndrome. The condition can be associated with multi-organ failure, sepsis, gastrointestinal hemorrhage, and pulmonary embolism. Ocular involvement of toxic epidermal necrolysis occur in 50 to 80%, 88% of cases, and it includes purulent form of conjunctivitis, corneal ulceration, anterior uveitis, entropion, dry eye syndrome, and severe visual loss. Pulmonary involvement is common but usually mild in nature, and only 10 to 20% requires ventilatory support. Reported pulmonary complications include tracheobronchial mucosal necrosis, pulmonary edema, acute respiratory distress syndrome, and pneumonia in 20 to 50% of cases. Erosive and ulcerative vaginitis, vulvar bullae are seen in genital involvement. Now, the long-term sequelae of the complications are long-term complications include xerophthalmia, ectropion, entropion, symbolobifron, corneal opacity, Spanish formation, nasolacrimal duct obstruction, and punctal stenosis. Then vaginal synechiae, obliterative bronchitis or bronchiolitis, bronchiectasis, esophageal stricture, recurrent cystitis, lingual ulcerations, and recurrent oral aphthous ulcer. The presence of extensive necrolysis, idiopathic nature of the disease, old age, elevated urea, creatinine, glucose levels, neutropenia, lymphopenia, and thrombocytopenia are linked to bad prognosis. Then there is a Scotland scale, which has been validated to determine the mortality rate and is considered to be the gold standard for prognosis. So we'll see what is this Cotton scale. It includes the risk factors like age, which is divided into less than 40, more than 40, then associated malignancy, heartbeat less than 120, more than 120, serum blood urea levels, blood urea nitrogen levels that is less than 27, more than 27, detached and compromised body surface area that is less than 10%, more than 10%, then serum bicarbonate level more than 20, less than 20, and serum glucose that is less than 250 and more than 250. So for in our case, the Scotland score is 4, which corresponds to the mortality of 58.3%. So next is a drug provocative test often needed when evaluating this patient for correct causative agents and for the preparation of a list of drugs to be given to this patient. Since a drug provocative test itself can cause reaction, it has to be done under proper medical supervision. Now the management part. So toxic epidermal necrolysis behaves like superficial dermal burn with the fluid shift, hypermetabolism, high nutritional requirement. So the initial aim should be the prevention of secondary infection by good wound care, as this is the most common cause of death. Early diagnosis, early withdrawal of suspected drugs, and the early transfer and management of this patient in specialized unit like intensive care burn unit are associated with the survival benefit. Wound management with the non-adhesive wet silver nitrate dressing maintains the moist wound environment. It speeds the reepithelialization, minimizes the pain, and decreases the infection rate. Wound should be treated conservatively as much as possible, as blister skin act as natural biological dressing and favors the reepithelialization. Biological and biosynthetic temporary skin replacement, for example, porcine xenograft, then BioBrain, that is skin substitute, and Aquagel, that is moisture retentive hydrofiber dressing that releases the silver within dressing, are the latest modalities of the skincare. Umbilical cord mesenchymal stem cell transplantation is an attractive and promising tool for skin generation in patients with severe denudation due to their self-renewal capacity, multilineage differential potential, paracrine effect, and the immunosuppressive properties. Pain control is very important part of management of SJS and 10 as this patient experience low intensity background pain. Longer acting opioids and paracetamol should be given for pain. It is important to encourage oral feed to avoid adhesions in the upper GI tract, but parenteral feeding may be considered when nutritional requirement cannot be met with the oral intake. SJS and 10 patients have impaired temperature control due to loss of integument and should be cared for in rooms with the temperature and the humidity control. Careful monitoring of the fluid balance with the strict input-output chart is essential because of the significant insensible fluid losses resulting in dehydration and renal impairment. Eye care includes 1 to 2 hourly eye lubrication and early involvement of ophthalmologist. Non-healing corneal ulcer may be treated with the bandage contact lenses and the amniotic membrane transplantation for severe persistent corneal damage. Now we'll see what is specific management. The use of corticosteroid is debatable and remain controversial. Corticosteroid have anti-apoptic role in the skin tissue. It inhibits the initiating pathways, down-regulate the fast ligand in apoptotic tissues, and studies support the early use of high-dose corticosteroid, that is 1 to 2 mg per kg per day of prednisolone for 3 to 5 days. Dexamethasone 8 to 16 mg per day is recommended. However, the dose can be increased to 4 mg the next day if considered necessary and recovery is not adequate. On the other hand, opponents to the corticosteroid suggest an increased risk of sepsis, prolonged hospital stay, and increased mortality. Other reported medical therapies for treatment of TEN include plasmapheresis, IVIG, and cyclosporine. The literature reports the use of early use of IVIG, which is safe therapy even for children with severe cutaneous drug reaction. However, there are conflicting reports as well. Cyclosporine, if given early in the treatment, arrests the progression of disease without increasing the risk of sepsis. The mean duration of reepithelialization and duration of hospital stay were significantly lower in patients receiving cyclosporine in comparison to those who were managed using supportive treatment only without increasing mortality. Plasmapheresis therapy to remove drug metabolites and cytokine from circulation remain controversial. Although beneficial effect of the cyclophosphamide 40 and tacrolimus 41 is suggested by some authors, large studies are needed to clarify these results. Then other treatment that have been tried include chimeric anti-TNF alpha antibody, that is infliximab, and thalidomide, as cytokines such as interleukin 6 and TNF alpha are found in higher quantities in skin of the patient of toxic epidermal necrolysis. Recombinant granulocyte colony stimulating factor in a dose of 5 microgram per kg per day for 5 days leads to the rapid reepithelialization of the skin as reported in some case report. But still, their use remain controversial and more robust data are required to make this treatment a standard of care. There are still gaps in our understanding of pathophysiology of Stevens-Johnson syndrome and 10 and available treatment options. So the good quality of multi-center studies are needed to understand the disease better and explore the treatment option further. Thank you.